Physiological anemia. In the utero, the child is exposed to low oxygen saturation, hypoxic state. So, and in fact, it is 70% of the normal. So, thereby, there is erythropoietic drive. In fact, erythropoiesis goes up, erythropoietin level is higher, and these children have thereby more reticulocytes, 3 to 7% something. Normally, it is much lower, less than 1% something. So, hemoglobin also is higher. The neonatal hemoglobin and early infancy a little bit high. So, it is how much? 18 gram, 21 gram something, and so ultimately in the little bit of a few days and within the neonatal period it normalizes. So there is the dry hypoxic drive reduction, and ultimately normal hemoglobin, normal oxygen PaO2 saturation 95% or so. Thereby the erythropoietic drive no longer exists and erythropoiesis declines. So you have how much hemoglobin, 11 gram per DL at 2 to 3 years, which is called physiological anemia of infancy. And in premature infants, this phenomenon is exaggerated. Here it is much lower hemoglobin, like 8 gram per DL. Here, apart from this erythropoietic activity of the bone marrow, you have less RBC survival, and you have may have folic acid deficiency, vitamin A deficiency. You may have little bit of blood sampling related anemia. So combination of these things giving rise to anemia of prematurity. Thereby, these two states must be kept in mind before embarking in the other diagnosis of anemia in the early infancy, and they are to be treated. The iron deficiency, iron replacement, certainly 3 to 6 milligram per kg per day. I know the elemental iron in some case, some preparation, one third, in others it is 50% something. So know this value and give iron for 3 months or so something, and make sure that the food rich in iron are being consumed. And very rarely, when something else supervenes upon it, some other disease like infection, sepsis, you may have this hemoglobin further low, less than 6 gram hemoglobin, you might need to transfuse the child.